just clicked on 1 o'clock. Welcome to Pelvic Health Melbourne's discussion today on intimacy pain. So I'll just wait till a couple of you have got your audios going. I'm going to be here today chatting with Nicola. So Nicola also works with us at Pelvic Health Melbourne and has a particular interest in intimacy pain, PCOS and endometriosis and the management for that. So guys, I'd love you to ask plenty of questions as you go along. Again, the chat should just be to me, but if you want to tick on anonymous, that'll make sure it's just me so that your questions are anonymous and that we'll just Nicola and I are just going to chat along the way. So, Nicola, what were you keen to kind of talk to our community about when we kind of talked about this intimacy pain discussion point?
I guess from my point of view, the main things that I wanted to touch on were the common causes of intimacy pain, because unfortunately it is a lot more common than what you'd think it is, and how intimacy pain can link into things such as endometriosis, polycystic ovarian syndrome, recurrent thrush and UTIs, and just how they interact with one another, and then what you can do about it and how we can help as physios.
Awesome.
Yeah.
Okay, so don't forget everyone, the chat, we're going to cover sort of three main areas today. So I'll just go over to the slideshow now. And we're going to cover peripartum intimacy pain. Some of our nurses actually requested this because they've been having more questions when you guys are going into your postnatal checks about new intimacy pain after having your babies. So I'm just going to share the screen with you and we'll have a little chat about peripartum intimacy pain. And then Nicola's going to go on to intimacy pain in youth. Now, obviously that's when you first become intimate, but sort of late teens, 20s. And why might someone have intimacy pain in that stage of your life? And then also talk about, if we've got time, intimacy pain, perimenopausal. So intimacy pain we'll cover, as we said, for the peripartum woman, the young woman, the perimenopausal woman, and endo and PCOS will probably fit more into the young woman. But interestingly, we start to see endo rear its ugly head again sometimes in menopause. Quite interesting. You think it's over, but it can come back. So before we start, I just wanted to go over normal sexual function with you guys because I think it's really important to understand our anatomy. It is uncommon to orgasm with penetration. So only 25% of women, when surveyed in broad studies, actually orgasm with penetration. Most women need a combination or external stimulation. So if you have a look at the image on the left, that's how large the organ is and where it sits. It is believed that the G-spot is about 4 centimetres in on the front aspect. Yeah, if you're coming in onto the front aspect, and we actually think it's just the G-spot's actually the back of the clitoris, is the more recent belief, and so you're actually contacting more of the organ. You know, if you place the finger on the inside and then also on the outside. In the image again on the left, you can see the blood supply going to the bottom of the clitoris. Now that blood supply is embedded so closely enmeshed in the pelvic floor. So pelvic floor dysfunction, either down or up, being weak or overactive, can significantly affect your pleasure sensation because it affects the blood flow to the uterus, to the clitoris. So I kind of say, imagine if your partner's male, imagine cinching your partner's penis. It makes it very difficult for them to achieve orgasm and or to achieve full sensation, pleasure. Let's go on to again, this is an image of the one on the left of it in graphics, and then the one on the right, you can see the superficial muscles of the pelvic floor. The clitoris is actually embedded within it. So the importance of pelvic floor health for intimacy health is crucial. Thus, why physios are involved. So normal sexual function in the male, I'll talk again a little bit if we've got time as we go through about the male. So it's normal for most men to get 4 to 6 erections overnight. They may not be full erections, but it's just about blood getting into the sponge of the penis, if you like, which needs to be engorged with blood to maintain its tissue alive and also maintain its length. All men will develop prostate cancer if they live long enough. Just an interesting fact for you to know. Early signs of prostate cancer or prostate enlargement can be bladder urgency, or slower flow or stop-start flow. And it can start from around 40 with our men. So maybe earlier than you imagined. So if you've got men folk in your home and you listen to them pee, just make sure the flow is nice and continuous. The other really interesting thing when we talk about erectile dysfunction for men, it is unbelievably common. 40% at 40, 50% at 50, 60% at 60. These statistics are consistent with the research as we go on. And I think as more men start to get involved in optimising their pelvic health, hopefully we'll see some changes in these statistics. We've got some really fantastic research now that pelvic health strength and good function correlates with erectile function. The most common thing that starts is premature ejaculation, so that they can't last as long and that the penis is not as strong, not as rigid. And the biggest thing for our men folk health in terms of erectile health is their heart health. So we always say heart health is synonymous with hard health. So keep your men folk fit for good function for long periods. So that's kind of normal. And now we'll go into some of the abnormal stuff that you may be experiencing. So let's talk about the peripartum woman, just because, again, we've been asked to do that. Now, I'm going to actually jump off this screen because I can't see any questions. Okay. So please, again, don't hesitate to put your questions in on the side. Anything to do with intimacy, orgasm, dysfunction, anything you're worried about, and we'll hopefully be able to answer your questions clearly and to assist you today. So for the peripartum woman, new onset of intimacy pain, two parts. One, it can be due to vaginal trauma with childbirth. So there might be scar tissue there. The difference is if you get scar tissue on any part of the body, normally movement helps break that scar down. In the vaginal tissue, there's not that much movement that occurs except with intimacy. And so if you find there's a little spot where there's scarring, and you can tell, it's kind of like if you think of the entrance as a clock face, there might be an ouchy bit over at 5 o'clock. Don't be frightened to get your hands there, not the whole hand. The thumb is often really easy at the bottom part, and have a feel. If you can feel a gristly section or a section that's just a bit thickened, you can start some really gentle massage. Use some lubrication, and we'll go through lubes. Nicola will go through lubes when she talks about her section. So it works a treat. You do it sort of every second day, and normally it's settled down within 2 weeks. Sometimes you can do it in the shower if you like. No more than a couple of minutes, and you should feel it soften under your fingers. If it's not breaking down or you're really worried, of course, come in to see us, and we can use ultrasound as well for that. But I find that works a treat for just the localized scar tissue from birth trauma. Next, there is the pain that you might get. So we always ask, if it's on penetration, is the pain entry or deep? They're different things. So if it's entry, it tends to mean there's either a scar spot on the entrance or the entry has become sensitized. Don't know if any of you have heard of things called vulvodynia, vaginismus. Again, Nicola will talk about it a bit more. But any conditions like that, when you have a trauma, you might start getting more sensitive to light touch. Your pain might be more burning, and you might get a soreness that lasts for a couple of hours or a couple of days after intimacy. If you have this one, please see your GP or a pelvic health physio, because that's a pain syndrome you've developed. The deep pain is normally really simple to fix. After having babies, we're all tending to suck our stomachs in and tighten our pelvic floor, because everyone says, get your pelvic floor on. And so often we see a lot of our women with overactive pelvic floors. So you think yourself, if you tend to be a jaw gripper, or if you tend to be tense in your shoulders and you actually touch them, they can cause pain. So we call it's a headache in the pelvic floor, and it can create pain on touch or deep penetration. That one is the easiest to fix. We just work on down training in the clinic. My idiot proof, if you like, little trick is if you've got a pen handy, put a dot on your hand, really huge dot, and every time you see that dot for the next 3 days, I want you to bring your focus to your pelvic floor and let it go and get a sense of, am I gripping? yeah, and try and change that habit. You don't need to be holding that pelvic floor on all the time. You weren't before you had your baby, so why are you now? So pelvic floor tightness is the big one for intimacy, deep pain. Lubrication, actually we will talk about it now, Nicola, because it's really important for peripartum women as well. So after having your baby, your hormones are completely different, as you know, and 40% of the energy or your metabolism goes to the boobs, and you're de-estrogenized. Yeah, it's kind of like you've got a perimenopausal vagina. It's dry, so you definitely need to slip, slop, slap. I say to my women, put down a towel, yeah, slap on you and your partner heaps of lube and go gently. The other really important thing, if you're just coming back to intimacy after having a baby, I know it's nerve-wracking. The best way is you on top or you side lying with partner behind, assuming your partner's a male, of course. Yeah. So if that just decreases the depth of the penetration, with you on top, you can control your speed. Yeah. And if there's any soreness, you can jiggle away from the soreness. So really important. Now let's talk about lubes. At Pelvic Health Melbourne, we love Uberlube. It's our favorite lube. It's a silicone-based lube. The only problem, there's no problem with condoms with these, is there? So that's only oil-based. You've got to watch oil-based with condoms, but Uberlube is fabulous. You only need a small amount. You can buy this online or come into our clinic and get some. It's gold, absolutely gold. Nicola, what lubes have you got there?
So I've got Olive & Bee. So Olive & Bee is a more natural-based lubricant. Unfortunately, being an oil-based lubricant, you can't use condoms with it. But the beauty of this one, which I will touch on in when I speak a little bit later, is that the olive oil in the Olive & Bee, like all olive oil, is really moisturising. So I feel like this is a bit of a double whammy effect, where sometimes with intimacy pain, if you're more likely to be dry down there, if you've got dry hands, you put moisturiser on. If you've got a dry vagina, put moisturiser on. And this one doubles as, I can either use it as a lubricant or I can use it as a moisturiser. You've spoken of the Uberlube, and then there is also water-based lubricants. This one's not a lubricant, this is a moisturiser, but this brand, yes, does also make a water-based lubricant that does have some moisturising qualities about it.
But we don't tend to, in the peripartum and perimenopausal period, recommend water-based. They absorb into the tissue too fast, and whereas the silicone-based sit on the skin and the oil-based sit on top of the skin. So the biggest complaints that we get is that it chafes or it irritates because you haven't got your natural lubrication. And that takes quite a while to return. So that's common questions we get asked. When is it back to normal? When your period is returned and you stop breastfeeding. So that could be 18 months down the track. Of course, for some of you, things will return to normal or better than normal afterwards, but it all depends. Please, guys, don't hesitate to ask any questions. Put them private so that it's confidential, and we'll just chat about anything that you've got concerns about in terms of intimacy, orgasm change, or pain with intimacy. So over to you, Nicola, to talk about the young woman. So we've kind of covered the peripartum intimacy pain. Let's go to the young woman with intimacy pain and the why.
So I will briefly say that, as I touched on before, intimacy pain in young women, assuming that they haven't had babies, is a lot more common than what you may originally think. And the unfortunate thing that I find is that a lot of my patients who'll come in with this have had it for so long, but they just haven't known that it's not normal, nor is there anybody that can help them with it. But the one thing that I want to get across is that there is a lot of help for women who are suffering intimacy pain. So as Alex mentioned briefly before, there are a couple of pain syndromes that can cause intimacy pain, mostly being vulvodynia or vaginismus. I don't particularly want to talk too much about them at the moment, and I more wanted to focus on, do you mind if I have the screen?
Yeah.
Yep, perfect. So there can be a range of causes why a young woman who hasn't had vaginal deliveries can have intimacy pain. And these can include things such as, so in our really active, athletic, female population, increase in muscle tension in the pelvic floor region is a really big cause for intimacy pain. And if you think like you've got really tight muscles in the neck and shoulder region, they can get really achy. And now if someone comes and touches me on the shoulder and gives me a bit of a pinch, I might jump through the roof. Same happens with the pelvic floor muscles. So for some women, their muscles are really overactive, whether it be because they're an elite athlete or they just really like going to the gym and they're really tight and really tense in the pelvic region. And then when they're trying to have be intimate with a partner, it's like you're now pressing on these really tender spots and it can cause pain. So that's one cause. Another cause is dryness. So what I find amongst my patients is those who do have overactive pelvic floors are also more likely to be dry. So that's where lubricants come in really handy. And Alex spoke about the Uberlube. For my pain girls who are dry, I really love the Olive & Bee just because, like I mentioned, it's a double whammy where you get that lubrication for when you need it, but you also get that moisturization, and it's two birds with one stone. The beauty I find of also with the Olive & Bee is that the honey is thought to have medicinal properties, being antibacterial, antiviral. So that's another positive tick for me with the Olive & Bee. Again, as Alex touched on, with water-based lubricants, I find that they get absorbed really quickly into the skin, and some of them can go really tacky. And if you're dry down there and things go tacky, you're more likely to get friction, which is more likely to cause some tissue sensitivity and tissue irritation. And now you enter this bit of like a snowball effect where it can just confound on each other and get even worse. So that's why for me, lubricants are a big tick, but I also really love vaginal moisturizers. So like I said, if you've got dry hands, you'd slap on some moisturizer. If you've got dry vaginal tissues, the same applies. And this one here is, I think, fantastic. Again, with dry tissue, it's generally a bit stingy, a bit burny. You go to the toilet, you wipe, and you can just feel it after you walk away. With the vaginal moisturizers, it's just nice. And I have all of my girls come back and say to me, it just feels really nice when I put it on. And I'm a big one for getting as much positive sensation and feel good sensation in the area, because when you're living with pain down there and you're living with intimacy pain, it's not a very nice experience. So as much nice, pleasurable feelings in that area, I really push for. As you can see on the slide, so another one which a lot of people find really surprising is for women who have a history of bladder or bowel problems as a child, is also a really common cause of intimacy pain. So that might be, you might have a young girl who in childhood doesn't like doing a poo at school, or is prone to some constipation, or has a bit of an overactive bladder, and therefore that also feeds into the overactivity, where we now have a pelvic floor that's holding on, and you've got those tight and tender spots that when you are trying to be intimate and they're pressed upon, they don't feel very nice. Another one that I find in a lot of my patients is recurrent urinary tract infections and thrush. And the reason that these can increase the likelihood of suffering from intimacy pain is that because they cause inflammation in the area, if inflammation is allowed to persist for too long, it can now start to cause nervous system changes, and that the tissues and the muscles in that region become more sensitive. So once upon a time, they wouldn't have reacted to light touch, but now because they're constantly being overwhelmed with inflammatory, I call it an inflammatory mess, but inflammatory chemicals in the pelvic region, these tissues now just become sensitive and they will react to light touch. And unfortunately with pain, it's really common for young women with intimacy pain to have some anxiety. And as we all know, when we're feeling a bit stressed and anxious, our muscle tension increases. And I hope everyone can start seeing a bit of a theme here, but then we can have on top of that another layer of muscle overactivity, because your muscles are also going to protect you if you're in pain. It's just a natural automatic response. Is if I feel vulnerable, if I feel pain, my body is going to react, and that is generally with tension. And finally, a big one for me is endometriosis, polycystic ovarian syndrome. I'll also put in there adenomyosis. So although these are very different conditions and conditions in their own respects, they have a huge impact on intimacy pain. And I don't have the exact statistics with me at the moment or in my head. However, there is a really large percentage of young women who do have either one of these three conditions and then do suffer from intimacy pain. And the reason for this is that because these three are, in a nutshell, inflammatory conditions. And as I mentioned with the recurrent urinary tract infections and recurrent thrush, is that with inflammatory conditions, if they're allowed to persist for long enough, they sensitize the tissue in that region. And that tissue is now more likely to react to things such as light touch. And if allowed to continue, can really be very damaging for the well-being of these women, as it puts a really large strain on not only their mental and emotional health, their relationships. And unfortunately, I see a lot of my patients who walk into the door are in this cycle. But there is help out there, and I think us at Pelvic Health Melbourne, we do a really great job with working with our patients with intimacy pain. And it's a bit of a journey. It's certainly not a quick fix for some people. However, there is so much that can be done about it. And I'm a very big one to advocate for speaking about what we can do and what we experience with this. In terms of what we do from physio management, aside from the lubricants and the moisturiser, we have so many tools up our sleeves. I really love using desensitization techniques, which is, as what Alex alluded to before, touching in the area, light touch to get the nervous system used to the fact that this is not threatening, and that we start small and then we build as our women can. Things like soft tissue massage, I really love. The down training, as Alex mentioned. For some patients, they work really well with, if you've heard of TENS, it's not labour TENS, it's a lot more comfortable than labour TENS, but we just have a lot that we can do for intimacy pain. So women do not need to suffer in silence.
Thank you, that was awesome. All right, so in terms of, tell us a bit, in terms of the endo in particular, endo or PCOS, why does that cause a problem? Why does endometrium in the tissue actually give intimacy pain?
So in terms of endometriosis, so with endometriosis, we have endometrial tissues that are outside of the uterus, and these can be so widespread. So it can be on the liver, it can be on the intestines. For some, it's been found on the heart. So this tissue will respond to hormones. As you could imagine, this can cause a lot of inflammation, because if you've got this endometrial tissue that is outside of the uterus and it is responding to your hormonal changes during the month, it's releasing things just into the stratosphere of the cavity in the body. And those chemicals, those inflammatory markers, they have to go somewhere. And they can be really irritant to surrounding tissues. And that's where we then get that sensitization, where the nervous system is so revved up and so reactive to everything that it just becomes really hypersensitive. So that then can lead to, I've got endometrial tissue on my liver, I've got it on my bowel. This is a really small area. So now my muscles can start reacting to this. And it's in terms of my muscles are going to protect me because I'm generally in lots of pain. So they're going to want to protect me, and they become tighter, and then it just feeds into itself. And before you know it, you're in this cycle of persistent pain and not sure what to do. In terms of PCOS, PCOS is a syndrome where it affects the hormonal system. And for a lot of women with PCOS, it is also connected with a large degree of inflammation. And as I mentioned earlier, unfortunately, inflammation, if it's allowed to persist, spreads beyond the initial site of concern. And now we get more of a systemic response. And we're starting to impact on areas a little bit more distal, again being the pelvic floor, where we can see an increase in sensitivity, an increase in muscle overactivity, and again just feeds into this really uncomfortable mess.
Mm-hmm. So how does it differ? So let's think of you've got a pain patient that might be long-term endo, PCOS, scar tissue, lots of surgeries, versus what you might do with a postpartum woman who's got intimacy pain associated with maybe some trauma, and it might have been there for a while. Does the management differ much in the clinic?
Yes. So actually, I take that back, yes and no. So for my endo and PCOS girls, generally there is a lot going on in that situation. And there is a degree of a term called sensitization that we've been repeating a lot. So with sensitization, it is a nervous system interaction as well. It's not just a muscle issue, it's now also a nervous system issue. For some women who have had pain for so long, they have changes in the way that pain messages are being signaled. And this is where things such as the TENS, where we're now wanting to work more so on that nerve impulse, can be really useful. And we also may, for a lot of my patients with endo and PCOS who do have intimacy pain, we may also need to call upon some pain specialists, because they may be in a situation where they've had a lot of central sensitization, so that nervous system is really fired up, where my management can only take it so far, and we might need some bigger guns. And some of my girls will be on some oral medication to help calm that nervous system down, or some topical medication to once again calm that nervous system down. Generally speaking, with our patients who have had traumatic deliveries and have had some vaginal trauma with intimacy pain, I don't generally see the same degree of sensitization as what I do with my endo and PCOS girls. So generally speaking, we can get a really good handle on our postnatal women with some touch to desensitize, some down training, lubricants, moisturizer if we need to. However, our endo and our PCOS girls sometimes will need that little bit of extra help along the way from a pharmaceutical point of view.
And where does massage, stretches, mindfulness, where does all that fit in your pain pathway or your management?
So that plays a really big role for me. So the way that I like to explain it to my girls as well is that the muscles of the pelvic floor are no different to the muscles of the shoulder, to the thigh, to the calf. It is all skeletal muscle. And when muscles are tight, I find they really respond well to some massage. So that therefore means that my treatment may include both internal and external massage to release those overactive, tight, tense tissues. And I mention external massage as well, is that because, as you would know, I've got one area of tightness which can lead to another area of tightness, which can lead to another area of tightness. I find my big ones are tummy. A lot of young girls, unfortunately, fall into habits of sucking their tummies in, which can lead to overactivity in the abdominal region. I also have a lot of girls who really like to squeeze their bum. Not sure why, but I fall into that as well. And that now creates tension in the glute region. The glute region and the abdominal region feed into the pelvic floor region. So now you've got this box of tension. And that's where I find, one, the soft tissue massage is really helpful. And also, Alex touched on the down training. I think it is a really underappreciated little exercise to do by just being, and everyone can do this right now, but just having a moment to really be mindful of how you're carrying your body. What am I doing with my jaw, my neck, my tummy and my bum? They're my main areas. Am I holding any tension? And if you are, just let it go. And the more you do this consciously, you'll be surprised how much you do it subconsciously, or the more you do it consciously, the more you do it subconsciously. And it's something that my patients will weave into their day and realize, when I started this, I was holding my tension at 70%. Now I'm barely holding, or it's become such an automatic task. And there, because I am not in this really tight, tense, protective mode, everything can back off, and it has really great flow-on effects to the pelvic floor. So now you've got an area that isn't as overactive and is more willing to allow touch into the area without pain.
Awesome. What about the orgasm? Does it change the ability of a woman to achieve an orgasm or the intensity of the orgasm?
I would say yes. Yes, it can.
How? How does it do that?
So a few different ways, but even if we just take the one, if a woman is in pain when she's intimate, she's more likely not going to be focusing on the task at hand and is going to be uncomfortable and not really present. So by alleviating her pain, she's more present to what's happening and is more likely to achieve an orgasm. 2, when the muscles are tight and tense in the area, it can impact on blood flow to muscles, blood flow to, let's say, the clitoris in the area. So by alleviating that muscle tension, we're now providing the best environment to get really fresh blood, really engorge that clitoris and increase the likelihood of being able to achieve orgasm once again. So awesome. Yeah, in short, yes.
Awesome. And just for those who, like myself, might be perimenopausal, unfortunately, changes happen again. And so the intensity of our orgasm can drop. Part of that is hormonal changes and skin changes, lubrication and tissue density in the area. So again, the lubrication additional lubrication can really assist. Nicola, can you just tell us, because I'm thinking about some clients now that haven't fit into any of these cases we've talked about, C-scars and intimacy pain, coccyx pain and intimacy pain, and maybe even sacral stuff, so say pelvic girdle pain during pregnancy. And how does that cause intimacy pain for women, and how do you help it? How do you fix it?
Yeah. So C-scars, they can, as all scar tissue is not the same as your normal muscle or skin tissue. It acts differently. So it can be quite thick and can adhere to things around it. That therefore can cause pain. And once again, when I'm in pain, I'm more likely to be tense in the area. Mm-hmm. To put it simply, the abdominal muscle and the fascia can become continuous with the pelvic floor fascia. So if I have a really painful C-scar and movement hurts, so I'm protecting through the area, I'm more likely to be tight and tense through my tummy. I'm more likely to be tight and tense through my pelvic floor. So once again, I'm already starting to create a scenario for pain through muscle overactivity. I'm going to continue talking about C-section scars. So if I'm that pain is allowed to persist for a length of time, that is seeing changes happening at a nervous system level. This is now flowing into that coccyx pain and sacral pain again. If that pain has been allowed to persist for long enough to cause nervous system changes, it is in a situation now where the muscles of the pelvic floor are more likely to also respond in a pain way to things such as light touch. So for those type of patients, again, we need to trace back to when did this all start? When did your intimacy pain start? Well, actually, it's happened after I had my C-section, and my scar's been really sore now that I talk about it, or I've had this coccyx pain for 2 years now, and that really doesn't seem to be getting any better. But now all of a sudden, I'm trying to be intimate with my partner, but things just don't really feel nice down there. I feel like it's really stabbing or burning. It's indicating that there's a degree of, again, sensitization to that nervous system. So my treatment doesn't really change. It's still a lot of soft tissue work. It's still a lot of down training, body mindfulness. If I need to pull in those big guns of the medications to help with that sensitization, I will. However, and saying that, I find a lot of the time we don't necessarily need to go to that point, because the combination of addressing if there's any muscle overactivity, so the soft tissue work can really help. Releasing those tight structures can really help. Making patients aware of how they're carrying their body during the day. Are they sucking in? Are they sucking their glutes? Well, if I've got coccyx pain, how am I sitting? What's my chair set up like? Is there little things that I can do at home to start alleviating that tension? I really do find that these have a big impact on the intimacy pain down the track.
Awesome. Thank you. Don't forget, ask some questions. We've only got 10 minutes left. So please ask any of your questions that you want to know, either about yourself or someone else in your life who may have intimacy pain long term. I'm going to jump now. Have you covered what you wanted to cover with the kind of young woman? Awesome. Yeah. I'll go now to the perimenopausal woman, which, you know, I'm sitting in now, and what tends to happen for us. So important to know that perimenopause starts at 42. The average age is 42 to 52. So it's 10 years of slow changes. The first thing that you may notice in terms of that menopause is coming on is that periods start to get a bit irregular and they may get heavier. The uterus itself actually grows. So it can grow anywhere up to 18 centimetres. The normal growth range is only 1 centimetre larger, from a 6 to 7 centimetre small organ to about 8 centimetres. But if you develop fibroids, and it's really important to ask your mother what her history was, because you'll hear a lot of the generation, my family's generation, my parents' generation, they had hysterectomies early. It was pretty much just take the uterus out for most things. That's changed a lot in terms of management now. So important to ask, why did they have their uterus taken out? Was it because of excessive fibroid growth? Because that's very familial, as in if your mum's got it, it's likely that you and your sisters will have it. So important to know, because as that uterus enlarges, that puts massive pressure on everything else. It's not so much often a pain issue, but it'll be clumpy, you know, periods, heavy periods. It might put pressure on bowel, it might put pressure on bladder, on other structures in that space, as well as prolapse symptoms, because it's a lot heavier and it can drag down. So you might get a sense of a lump in the vagina, all the fun things that are involved with being female. I'm going to jump back because something Nicholas said made me think, particularly in terms of the hormone changes with PCOS and endo. We've been really privileged. We've been pushing to be able to service the LGBTQIA+ community, and we've had quite a few transgender individuals come through. And it's fascinating for those men who are still suffering with what they call Shark Week, their periods. And because they're on hormone therapy of increased testosterone, that will often make their period pain a lot worse. So it's really interesting in this field, as we have the privilege of seeing many different individuals with many different experiences, and how significant hormone influences can be on pain and regulating that hormone. So that's a bit of a segue, probably not relevant, but it was just something I thought about. Where were we? What was I talking about, Nicola?
You were talking about, you got me with that comment.
Yeah.
Perimenopausal hormone
changes.
Yep.
Okay. So we talked about definitely the heavier bleeding. Then, we talk about the 8 dwarves of menopause. Remember, it's going to start at 42. Get ready for it. Heavier periods generally. Then you might start noticing food sensitivities. Foods you were never sensitive to before start becoming a problem. Lactose, often first, same with onions and garlic, then gluten will hit you. So you'll tend to produce more smelly wind. Remember, normal wind 13 to 24 times a day. I know that's a lot. That's considered normal. If you're producing more than that, it's likely you're starting to get food sensitivities. If you're producing painful wind, really smelly wind, that's an indication the food is no longer happy in your present gut. So constipation becomes a bigger issue, and that's why you'll often hear your parents or grandparents talking about their daily ablutions, because it becomes a big deal as we get older, that those issues can become more prevalent. So the joys are constipation we've got to look forward to, food sensitivities, and bladder urgency. So now not only do I have to go more, I'm busting when I go. Then pelvic floor from 40, our anal tone decreases, thus the pop-offs in exercise classes for the more mature women. So don't snigger too much, because it'll be you one day. So all the joys that happen to women. So our hormone level changes significantly earlier than our men folk, and we get a dramatic decline postmenopausal in estrogen. And estrogen's huge for our skin and for our organs, heart, bladder, bowel. So we always say, and I love Nicola mentioned it, we moisturize, we do stuff to our face, but we forget about down there. It dries up, yeah? So the skin, the vaginal tissue, postmenopausal is very different. Gets quite thin, pale, and dry, and even dry to walk. So some people's tissue will be significantly dry that they chafe when walking, or they bleed when wiping. Again, that's quite severe. And those are the women generally who've had a very early hysterectomy or went through, menopause very early without HRT. That's really chatting about all this stuff with your gynae is so crucial. Guys, you have 5 minutes left. Don't be shy. You've got to have something to talk about your bits. How can we make your sex drive better? How can we help with your menfolk? Ask a question. Of course, you can ask a question another time. I'll leave my email. So it's alopez@pelvichealth.melbourne. Nicola is nicola@pelvichealth.melbourne if you want to ask us any questions privately, and we can answer those. So the other things to look forward to with menopause is the night sweats we know about, the moodiness, the forgetfulness, and then night wakefulness. So exercise needs to change. You shouldn't be thrashing yourself anymore with high intensity training, or if you do, you need longer recovery. You don't sleep as well, so you don't get as much deep sleep. You often have very light sleep for a few hours overnight, so you don't get that muscle recovery that you did when we were younger. As well, our muscle mass drops 10% every decade. So from 20 to 30, it started to drop. The biggest drops 30 to 40, 40 to 50. So we have to work 10% harder to achieve the same, in terms of our muscle composition. The other thing that happens, guess what? Our vagina gets smaller. Because of these skin changes that can happen, the actual entrance can get a little bit tighter. So for those with partners, again, I'm assuming it's a male partner who might be large, that can become a problem. Thus, you might have heard of physio stuff with dilators. It's kind of one of the only reasons we tend to use it at Pelvic Health Melbourne. We sometimes use it for pain and touch desensitization. All that is, if you've got a sore spot that's hypersensitive, we just get someone to touch it, hold for 15 seconds. It's not rocket science, but it works. And for our women who have pain for 2, 3, 10 years, to get them pain-free, we love our work. It's just so thrilling. To get a woman who's never achieved an orgasm, my God, we're all high-fiving at the end of that day. So I think if you guys can take anything from this, is talk about it. Talk about it with your friends. Talk about it with your family. We need to be talking about pelvic health. Remember, pelvic health is synonymous with intimacy as well as bladder and bowel, but it is about your intimate health. For your male partners who aren't potentially getting as rigid, turgid, tumescence, whatever you want to call it, that's often about the pump. So if you actually get your pelvic floor strength and endurance better, they can normally last longer and get a harder erection without the need for medication. And it's not a problem to start talking about with your partners. You might need some medication. The vascular system might be compromised, so it's hard to get inflow. How are we going? We've got 1 minute. Nicola, how would you like to wrap up our session?
Well, if no one has any more questions, I've touched on everything that I wanted to touch on. I don't have any questions for you.
That's okay. That's okay. So hopefully we've, kicked some goals. The only other thing might be for the men. So what does intimacy pain look like for the men? We see quite a few with intimacy pain. So it differs. They'll get, because for women it's mucosal. So we tend to get it much more around the vagina and inside. The guys will get anal pain, testicular pain, perineal pain, and urethral pain. They're the areas they get it. And we can tell what's causing it by where they feel it. Certain nerves from certain areas, so if it's from the sacrum, it'll tend to be more low sacrum, anal and testicular pain. If it's through the abdomen, it'll be low testy as well. If it's penile tip, it's normally neural. The nerves have been caught. And for our guys, it's mostly about stress, gripping, and they're sitting back on their sacrum. So They may be doing longer hours at work. They may be working from home with COVID, and they're starting to get some problems with ejaculatory pain, post-intimacy pain, and abdominal pain. So I reckon we can wrap up here. This, if you want to share it with anyone, will be going on our website under the blogs. And please don't hesitate to contact us if you want to discuss anything further.